First we know that. Now first we know that what is bipolar disorder. Bipolar disorder is also known as manic depressive illness, and it is a brain disorder that causes unusual shift in the mood, energy, activity levels, and the ability to carry out day-to-day work tasks. Now this is a graph which is reporting different type of disorders in a person seen. The green light depicts an average person in which the vertical axis is the the vertical up axis is denotes the mania in a person, and the vertical down axis denotes the depression, and the x axis denotes the time. The green line denotes an average person in which there are little ups, and sometimes he also suffer little down. In the cases of example, if he loses a job or he moves to a new city where he is alone. The blue line here depicts a unipolar depression. In this, the person have a little up, but he suffer major downs, and which is the terminal depression, and he recovers after some time, and after the mood comes into a normal stage. The light purple line here is the bipolar 1 disorder. In this, the person suffers from major depression, which is of more than 2 weeks or 2 weeks period. But he also suffers a high, which is known as mania, and which lasts for 1 week or more, and then he comes to a normal stage. The bipolar second type of disorder is can be denoted from the dark purple line, where the person suffer from a very low phase, that is depression, and he has a partial high phase, which is known as hypomania. Then which lasts for a period of 4 days or more, and can be last longer. But after some time, he have a normal mood. There is also a term known as cyclothymia, which is known as cyclothymic disorders. In this, the person has the partial ups and partial down. That is, he suffers dysthymia as well as hypomania cyclically for a period of 2 years or more. These are the in this the person in bipolar disorder, the person has a two phase. That is, he goes extreme low to extreme high, and this phase can differ from days to weeks depending on his condition. The extreme lows are the major depressive disorders. That in this, the person have symptoms of hopelessness or discouraged. He is also suffer from lack of energy and focus, and sometimes the physical symptoms he shows, that is a eating disorder and sleeping disorder, in which he either eat too little or too much. The he's by is that the person will episodes in mixed episodes. The symptoms of depression and mania occur at the same time. The other is that the rapid cycling, which I will discuss first. The rapid cycling is when the person has 4 or more episodes of depression or mania within a 1 year. This is termed as rapid cycling. Now, what is rapid cycling? Rapid cycling is defined on the following important features. That is, if there are 4 or more episodes of depression, mania, or hypomania, that must occur in the previous 12 months. Second, a euthymic between the manic and the depressive episode to be counted as 2 episodes. Third, number of episodes are tabulated rather than the number of cycles. That is, we count the episodes, not overall cycle. Fourth, the episodes are demarcated by a switch to an episode of opposite polarity. Now, this is a graph showing the rapid cycle mania. In this, we can see that the duration of the 12 months, we see 4 peaks in mania. That is, first, second, third. The fourth one is of hypomanic, which will also be counted as an episode. Now, this will show that the person is suffering from rapid cycling bipolar disorder. Now, this is second graph which shows 2 peaks upward and 2 peaks downward. In this, the person have 2 episodes of mania and 2 episodes of depression in a period of 12 months. Now, now we'll come on the etopathogenesis of rapid cycling. Pharmacological factors as well as non-pharmacological factors. The pharmacological factors consist of the drugs like such as TCS, SSRI, cyproheptadine, lithium carbonate, L-dopa, or monoamine oxidase inhibitor. Now, second is the non-pharmacological factors. These are consist of the non-drug factors such as electroconvulsive therapy, In females in pregnancy state, multiple sclerosis, cerebral sarcoidosis, grave disease, or such, if there is something accident, someone is suffering from accidents such as the subarachnoid hemorrhage or cerebrovascular accident, and patients suffering from thyroid disorders such as hypothyroidism. Now there are different types of rapid cycling, classified on the basis of time of onset, on which there are two: early onset and late onset. Early onset occurs when the affective disorder just start after the rapid cycle. The late onsets occur after some periods of slow cycles. The second division we make is on the causation, that is the spontaneous or externally induced. The third is on the cycle length, which is typically of three types: the classic rapid cycle, which lasts from 3 days to 12 weeks. The second is the ultra rapid cycle, which usually lasts for several days. This is the ultra rapid cycle, which is also known as ultradian. This cycle length is less than 24 hours. Now we come on the management of the rapid cycling, which can be done by the use of the drugs. The most common drug we use is the lithium. The other are the anticonvulsants like carbamazepine, valproate, lampotrazine, gabapentin, and topiramate. The benzodiazepines are also used, especially the clonazepam or lorazepam. Atypical antipsychotics such as clozapine, risperidone, or olanzapine. The L-type calcium channel blockers are sometimes also used, such as nifedipine, amlodipine, and isperidine.
Okay, have you finished, Nalin? Hello. Can we go to the next presentation?
Yes, sir.
Yeah. Any questions, comments? Meanwhile, we are loading other presentation. I think an important aspect in rapid cycling is very important is avoiding antidepressants. Rapid cycling is a diagnosis of actually the course. When we study the course, number of episodes of more than 4, so we should avoid antidepressants in the course, not seeing an depressive episode and then we give an antidepressant that actually pushes the patient into rapid cycling.
हेलो हेलो आया इसका याद है हाँ कर दीजिए नहीं
Good morning. Good morning, sir. Good morning, sir. My presentation topic is persistent depressive disorder, also known as the dysthymia. DSM-5 has consolidated chronic major depression and dysthymia from DSM-4 into a persistent depressive disorder.
Good morning, sir. Actually, the Wi-Fi is not working, so there will be no net issue. So that is why it's disconnected.
ऊपर आ जाओ या तो फिर या तो इधर बैठे वैसे तो मैं सर या तो दूसरे रूम में आ जाओ आई थिंक इन माय रूम
Connected. Good morning, sir. My presentation is on the persistent depressive disorders, that is the dysthymia. So the DSM-5 criteria for the major depressive disorders, and it includes 5 or more out of 9 symptoms, including one of depressed mood, loss of interest in the same 2-week period. Each of these symptoms represent a change from previous functioning. Depressed mood, loss of interest, change in weight or appetite, insomnia or hypersomnia, psychomotor retardation, loss of energy or fatigue, worthlessness or guilt, impaired concentration or indecisiveness, thoughts of death or suicide intention. Persistent depressive disorder can be irritable and duration must be 1 year or long. So it will never without symptoms for more than 2 months. So the symptoms, the signs and symptoms of depression and dysthymia may include the lasting sad and anxious or empty mood, feeling of guilt, worthlessness and helplessness, decreased energy, a feeling of fatigue or being slowed down, sleeping too much or can't sleep, restlessness or irritability, weight gain or weight loss, difficulty in concentration, making decisions and remembering, or there is a change in appetite. So these are. So the pathogenesis of depression, there is a cognitive impairment and the inflammation inside the brain parenchyma, and there is a vascular kind of a depression. There is a vascular change that will going to lead to the depression. So the specific criteria for vascular depression is old age, more than 65 years, if there are white matter lesions, ischemia, and a cerebrovascular complication. And there is inflammatory markers also raised inside the brain, including C-reactive protein, interleukins, TNF alpha, and PAI1. And there are other neurotransmitters there that is also lead to the pathogenesis of depression. So there is an increase in the cortisol and HPA axis dysregulation, and there is increase in the neurokinins. There is decrease in noradrenaline and serotonin, and there is a decrease in the melatonin. So these were going to lead to the pathogenesis of the depression. The causes of the depression, they are multiple causes. It's not like a single causes. So, and dysthymia is a very chronic form of the depression. Dysthymia disorder includes smoldering dysphoria, insidious onset, waxing waning quality, ongoing for more than 2+ years, and there is the brief period of euthymia. Double depression is something where there is a combination of a major depression with dysthymia. There are causes include like neurotransmitters that are naturally occurring in the brain, and they play a very likely role in a depression. There are life events when so any kind of a traumatic event that will going to lead to a major depression and can trigger persistent depressive disorder in some individuals. Dysthymia epidemiology include there are around 12% of the general population, that is the prevalence of the depression in the world right now. And in general, when it comes to the gender discrimination, the prevalence of the depression is 2 times higher in females than in males. And who is affected by dysthymia? Women are more affected 3 times as compared to men, and approximately 1.3% of the adults, they are suffering from the dysthymic their lives. And there are some conditions that are co-occurring with dysthymia or depressive episodes, 70% of the people they are living with the borderline personality disorders, and they will going to have a co-occurring dysthymia diagnosis. 30 to 40% of the people they have the mood disorders and because of the substance use disorders, and 80 to 90% people they are already suffering from the major depressive disorders. So these will going to lead and convert it into the dysthymic episodes. The risk factors of the dysthymia, there are multiple risk factors, and it's been a study. This image shows the relationship between the major depression and the cardiovascular disease. So there is inside the brain, the limbic system, the hypothalamus axis, the anterior pituitary. So they will going to cause depressive episodes because of the elevated secretion of cytokinins, TNF alpha, interleukins, and it will going to lead increase in the ACTH that will going to progress towards the myocardial ischemia and ventricular arrhythmia. So the depression can be attributed to the development of the cardiovascular diseases. The complications of the depression, they include starting like reduced quality of life, major depression, anxiety disorders, simultaneously mood disorders, substance abuse, relationship difficulties and family conflicts, school and work problems, decreased productivity, chronic pain and generalized medical illness, suicidal thoughts or behavior, personality disorder or other mental health disorders. And now coming to the last part, the treatment of the dysthymia. So first we need to go for the diagnostic evaluation, because dysthymia is now in the DSM-5 criteria. Major depression and dysthymia, they are considered as the diseases. So for the diagnostic evaluations, we have two options: pharmacological treatment and psychotherapy. So psychotherapy it includes, and this is a famous line from the Dunner, all treatment for depressive mood disorders are effective for the treatment of dysthymia. So talking about psychotherapy, so type of therapy is cognitive therapy, where we will identify, interrupt and correct the negative thoughts of the person. Behavioral therapy, it introduces positive actions that will going to circumvent learned helplessness and decrease the effect of the stress. There is interpersonal therapy, which will develop sensitivity to social rules. There is psychodynamic therapy. It examines the emotional conflicts in relations to the experiences and through retrospective introspection. And last is the supportive therapy, where we will educate, advise, reassure, and compassion all contribute to the patient support. So this will include in the psychotherapy of the treatment part. We also got the pharmacological treatment, which will depend upon the different individuals, and they include SSRIs. This is the selective serotonin reuptake inhibitors, tricyclic antidepressants, and other newer antidepressants. And if there is a no response, then we can go for optimization, substitution, augmentation. And if there is a remission, then we have to continue the treatment for 6 to 9 months with full dose plus psychotherapy plus booster sessions. Thank you.
Any questions, comments? Any difference in dysthymia as per latest DSM-5? Can you elaborate? Any differences in dysthymia conceptualization as per the latest diagnosis system, DSM-5?
Yes, sir. Inclusion of dysthymia is a major is a next step of the major chronic depressions, and it include poor appetite, insomnia, low energy, low self-esteem, and there are suicidal intention or suicidal attempt.
Important difference is, dysthymia, which was known as persistent depressive disorder, as per
Yes,
DSM
sir.
now. But we can diagnose dysthymia and major depression together now, as per DSM. So we should have a prior history of dysthymia prior to that. This was not very clearly given in previous diagnosis. Any other questions, comments? Because there are a lot of connectivity issues today. So I would say that both are presented well. But the only issue is that this, because of some connectivity issue, second presentation couldn't be coherently put out. And I would have appreciated if PPT would have been presented, so that former presentation is more easier to present and grasp. Any other questions or comments? Or we end this meeting then? Thank you. Thank you.
Thank you, sir. Thank you, sir.